From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Gregory Simon, who is a researcher and psychiatrist at Kaiser Permanente, Washington. Welcome, Dr. Simon, to this JAMA podcast.
Thanks very much for having me.
Great to have you here. So, to begin with, how common is depression, and how has the epidemiology changed in recent years?
Well, depression is probably the most common chronic health condition treated by primary care or other general medical clinicians. In any given year, there are probably somewhere between 6 to 9% of people in the United States who experience a major depressive episode or a clinically significant depressive episode. If you go into the waiting room or into the consulting room of a primary care physician, that number probably jumps up to 15 or 20%. Because depression is associated with conditions that people seek health care for, and because people who are depressed tend to use more health services. So in the population, 6 to 9% in a year, but in a primary care clinic, probably 20% or more.
And what was the effect of the COVID pandemic on the epidemiology of depression?
COVID certainly did increase the need for or the demand for mental health services. And there's some evidence that the pandemic increased rates of depression, especially among teenagers and young adults. And that is a big concern. We saw an increased demand for mental health services, I think, because there was more talk about the mental health impacts of COVID-19. So more people were seeking treatment for depression. Certainly, more people seeking treatment is a good thing if people get effective care. So we don't necessarily look at more people seeking treatment as a bad thing, but at least in some cases, for younger people, it may indicate increased rates of depression and an increased need.
Sure. Now, in what healthcare settings should we be screening for depression, and what is the best way to screen for depression?
The U.S. Preventive Services Task Force recommends screening for depression in general medical care. That's in primary care and other general medical settings, including in emergency department settings. I think that recommendation is well supported by evidence. We have evidence not only that short self-report questions can accurately identify depression, but more important, that when people are identified by screening, that effective treatment will reduce symptoms of depression and improve long-term outcomes. So the two key points about screening is, can we accurately identify and do we have effective treatments? And I think for depression, we can answer yes to both of those questions. There are many different short self-report screening questionnaires. Probably the most commonly used is the PHQ-9 or Patient Health Questionnaire, the 9-item questionnaire that screens for depression. It is accurate enough, and I think has been shown to be accurate across all types of people. Younger people, older people, people with chronic medical illness, people from different racial and ethnic groups. So the PHQ-9 has become the most common tool. It's not the only tool. There are other commonly used tools. The Edinburgh Perinatal Depression Questionnaire is often used for women who are pregnant or postpartum. There's a geriatric specific depression scale that's commonly used, but the PHQ-9 has become sort of a lingua franca and it works fine. We don't have evidence that those other specific questionnaires are better. So I think most large healthcare systems have adopted the PHQ-9. One common strategy is to use just the first 2 questions of the PHQ-9, which ask about depressed mood and loss of interest in activities, and then to only ask the additional questions for people who screen positive. That strategy works pretty well. It does not miss many people with significant depression, and it does reduce the time required. So either that PHQ-2, what we would say cascading to the PHQ-9, or the full PHQ-9 is probably the most common and well-supported strategy.
Excellent. Now, what symptoms or circumstances should prompt psychiatric consultation or referral?
When someone is identified by screening as having significant depression or might present with symptoms of depression to a primary care or general medical clinician, we'd recommend that that clinician assess some specific things that might indicate the need for specialty consultation or referral. Those would include suspected bipolar disorder, a history of having episodes of high or elevated mood or excess energy, not needing to sleep. symptoms suggesting psychosis, hallucinations, or delusions, or especially suicidal ideation with some specific plan for self-harm or intent for self-harm. All of those would be reasons to at least seek consultation or refer to some specialty mental health care. Although we must admit that specialty mental health consultation may not be available for all people in all settings. So if any of those three indications for referral are present, specialty consultation would be recommended. Although it is true that sometimes a primary care clinician might need to manage patients with those indications for referral, at least in the short term, when immediate consultation is not available.
Now, what is considered first-line treatment for depression?
We have strong evidence supporting specific psychotherapies as first-line treatment and antidepressant medications as first-line treatment. Both of those are effective. What we would recommend is that certainly for people who are experiencing at least moderate symptoms of depression, we would recommend one of those treatments. And for people with more severe or chronic depression, we would recommend both. There is evidence that both medication and psychotherapy combined is superior to either one alone, especially for people with more severe or chronic depression.
And which antidepressant medication is the best first choice?
There are more than 20 antidepressant medications approved for use in the United States, all of them safe, all of them effective, and the differences between them are relatively small. We can rank the available antidepressant medicines according to their likelihood of clinical improvement, and we can rank them according to tolerability, the likelihood that someone would discontinue medication because of side effects or adverse effects. If we line up all of the antidepressant medications along those two rankings, we could say that escitalopram and sertraline tend to come out on the top. They're two medications that you could say rank in the top 10 on both of those counts. But it's important to emphasize the differences between antidepressant medications, especially in terms of their clinical effectiveness, are relatively small. Any of those approved medications should be considered appropriate first-line treatments. There's no big advantage of one medication over any other.
And what do you recommend if first-line depression treatment doesn't work?
If first-line depression treatment included psychotherapy, and that is not effective alone, we would often recommend adding medication. If first-line treatment included medication alone and that was not effective, then second-line treatment might include adding psychotherapy, possibly trying a different medication. If first-line treatment included both of those together, if antidepressant medication and psychotherapy were recommended as first-line treatment, and that is not effective, then often we would recommend trying some different medication. Second-line medication treatment can also include combining medications, adding a so-called booster or augmenting medicine, or adding a second medication. So second-line medication treatment, there are options for switching medication or adding medication. There's not strong evidence that either one of those strategies is superior. That sometimes comes down to the patient's preference or the clinician's familiarity with certain treatments.
Thank you. Now, what are some considerations when treating elderly patients with depression?
Elderly patients with depression may more often have chronic medical illnesses which influence the choice of medications, so there may be medication interactions to consider. But we're especially wanting to avoid medications with significant anticholinergic effects in older patients. So that would usually mean avoiding all of the older or tricyclic antidepressant medications and avoiding some of the newer antidepressant medications such as paroxetine that may have stronger anticholinergic effects, since those can cause more cognitive impairment.
Excellent. Now, once a patient is taking an antidepressant medication, for how long should they continue taking it?
For people who are experiencing their first really significant episode of depression, who start an antidepressant medication and have a good outcome, we would usually recommend continuing medication for at least 6 months beyond that time of recovery. Continuing for that long reduces the risk of recurrence or relapse of depression after stopping. For people who have more severe or chronic or recurrent depression, continuing medication longer is recommended, sometimes for 2 years or more. So you could think of how long to take medication after getting better sort of depends on how hard it was to get better. people who took longer to recover, people who required second or even third line treatment to recover, we'd usually recommend continuing medication for longer.
That makes sense. Now, I know we touched on this a little bit before, but how did the COVID-19 pandemic affect treatment of depression?
The COVID-19 pandemic really caused a dramatic shift toward virtual or telehealth delivery of mental health care. There certainly was evidence before the pandemic that care for depression, including both psychotherapy and the monitoring of antidepressant medications, could be effectively done by telephone or by video call. But that was really a small part of depression treatment prior to the pandemic. In the pandemic, there was, as you may remember, the third week of March of 2020, mental health care across the country switched from mostly in person to almost entirely virtual, really over one weekend. It was the most dramatic shift we've seen in delivery of mental health care. And that has returned somewhat, although I think across most large healthcare systems, half or more of mental health care is still being delivered virtually. The evidence we have is that virtual care is just as effective, so there's no downside or no problem with that, and probably has actually increased access for some people who had difficulty accessing in-person mental health care. I know in the healthcare system where I work, people who lived in rural areas, sort of in the eastern part of Washington state, often had great difficulty accessing in-person care, and that's no longer a barrier.
That's good news. Now, my next question is, how can primary care practices improve effectiveness of depression treatment?
The key to success is not so much picking the right treatment to start with. The key is in the follow-up. So there are many different antidepressant medications. On average, they are all about equally effective. There are several specific psychotherapies that are proven effective for treatment of depression, all of them effective. Medication and psychotherapy, on average, about equally effective. But we know there's a very big difference between organized follow-up care for depression and usual care, which unfortunately is sometimes not very organized. The keys to success are making sure we have a systematic plan for follow-up, that we're systematically measuring whether people are getting better, we're asking people about side effects or adverse effects that may cause people to stop taking medication, and that we adjust treatment. If that first-line treatment is not effective, that we try a second-line treatment. We don't want to switch or stop treatment too early, but neither do we want to persist with a treatment for too long that is just not effective. Both medication and psychotherapy may take a few weeks to be effective, but if they are not effective within several weeks, it's time to move on to step 2.
Agreed. And I know in your review you talk about the role of the collaborative care programs. But my final question is there anything else generalists should know about depression that we haven't talked about?
One of the key messages, I think, is that depression is certainly associated with a wide variety of adverse life experiences. People who've had adverse childhood experiences, for instance, childhood neglect or abuse, people who've experienced traumatic events in their adult lives. Depression is fairly common among people who are recently bereaved, among people who have serious chronic medical illnesses. But it's important to know that for all of those people, even though they may have what some people would call a good reason for depression, that depression treatment works. What we do not want to do is to say if someone has a so-called good reason to be depressed, that means it's not worth trying to help them. David Goldberg, who's one of my heroes and sort of one of the people who pioneered improving mental health care and primary care, used to call this the fallacy of good reason. The idea that if there's a good reason to be depressed, then there's nothing that can be done about it. We know that depression treatment works, even for people who've experienced many of these significant adverse life experiences.
Yeah, that's very important. So I just wanted to clarify one question. When a patient is suffering bereavement from the loss of a loved one, how soon should one start treating depression? Is there any time limit on when one should start?
The research on this supports the effectiveness of both psychotherapies and antidepressant medications for people who've been recently bereaved. That is, even within the last 3 to 6 months. I would not say that we would want to delay sort of effective psychotherapy, waiting months and months and months after bereavement. And of course, psychotherapy for depression during bereavement would include things that would be helpful even for people who are very recently bereaved. It would be about scheduling activities that are positive. It would be about identifying and challenging sort of negative or self-critical thinking. It would be about building social support. So especially when we talk about psychotherapy, I would say for people who are experiencing really significant symptoms of depression, even who've been recently bereaved, there's no reason to wait.
Thank you so much. I'm Dr. Karen Lasser. I've been speaking today with Dr. Gregory Simon from Kaiser Permanente, Washington, about depression. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.